what your values are, what's important to you, because those caregivers won't get to know you. By the time they are caring for you, you won't be able to tell them what's important to you and what you did with your life and why this is the kind of ending that you want your life to have. So we think this is a very powerful tool to be able to help those who've been asked to implement something that they may not really understand much about. It's an opportunity for this patient who's voiceless to speak. The other thing that I think is important that patients who are people, they're not patients yet, who are completing this directive, they need to remind those around them that the person is trusting them to not substitute their judgment about their quality of life or whether they're comfortable or not. They are to follow the instructions, and that you are trusting them, that they care and respect you enough that you will do that. So this is something you don't just complete and then you put it away. You keep bringing it out, you keep talking about it, you become a big bore about it, but people need to know that this is really important to you. And if you change doctors, you bring it to your new doctor, for sure. Okay, so clearly there are some long-term care considerations that we should discuss, right? Because often, as you all know, when dementia becomes advanced, long-term care placement often becomes necessary. And in anticipation of transferring from home or from someplace else to a long-term care facility, before that place is chosen, the long-term care facility, I really strongly recommend that patients and their families, persons and their families, go around and interview them with your dementia directive. And say, at a time that you can explain why you're doing this, and be sure that they will honor it, or at least they're familiar with it, and that they understand that you've completed this very carefully and thoughtfully, and it's witnessed, and you've shown it to your lawyer and your physician, and will they honor it? Do that before you sign up and start paying money for that place. We recognize that in-service education will be necessary for the staff of long-term care facilities and the administrators, but I would say particularly for the CNAs, the nursing aides that provide almost all of the care for folks in long-term care facilities. They need to understand what this is for, what it's about, and it doesn't mean that you stop caring for or about that person. At mealtime, you don't just abandon the patient, you go in and you continue to talk to them and you continue to stroke them and you give them social human interaction, which is what people need, but you don't feed them, right? Need I mention, we do anticipate judicial review. We think we'll do well, and we've had many people who have volunteered, some in this very room, to defend us. Is that not right? That's what I thought. So how will we know whether this thing worked out? Whether this is successful as a document, as a directive? I suspect it might be a long time. I've actually had some patients ask me that. Well, do you know if it works yet? I said, well, actually not yet. Because, you know, people have to sign this document years ahead of when they think it's going to be necessary, please God. So when I was first fiddling around with this document and consulting with colleagues and talking to lawyers, I got a group of folks together who agreed to sort of pilot it, you know, that they would complete it and they'd tell me what they thought about it and what the process was like. And many of those folks, again, the man in particular, said absolutely they didn't want to have to wait around till dementia became advanced. And of the 6 who first completed this directive, 1 died of a self-administered lethal dose of medication. She was successful. And the other one was a Pulitzer Prize-winning journalist who lost his mind. And his family got him accepted by Dignitas. So the other 4 of that original 6 are still living with their diseases and comforted, I think, by knowing that they have this directive. So in summary, this directive was absolutely created in response to pleas for help from New Yorkers newly diagnosed with dementia and their families, and to demands for specificity by judges who had ruled in previous cases of hand feeding or not hand feeding. They wanted to have it very, very clearly marked out what the patient's wishes were. Our goal is to have it widely distributed and used by those wishing control over the length of the dementia-related dying process that they have. I hope nurse colleagues and others will help disperse this directive to those who might benefit from its use. And we welcome your feedback and your experiences from working with this document. Please contact me at any time with questions. That's my email address. And as I said, the phone number, I'll give everybody my card. Any questions you have, don't hesitate to call me. So I'm going to stop now, and Anne is going to come up.
So while I get this queued up, I also want to say thank you to Judy for inviting me, for answering my first email not very long ago. To everyone who's helped put this on, I am very excited to be here. Very excited to be here, very excited that this is where we're at and that we're starting to make some progress in helping people with dementia have their voice throughout their disease, and I think this allows that. I was a little afraid to be the next hitter after Judy Schwartz. And I was in a colleague's office the other day and I saw that she had a book that said how to give a TED Talk. And I thought, can I borrow that? I have to give a talk that, next week. And so I didn't have time to actually read the book, but I perused it a little bit, some of the major chapters, and it said, talk with passion. So I said, okay, I'm passionate about this. I got that one down. And it said, don't bury your lead. So I looked at my talk and I didn't have to change anything, but I had to completely rearrange them. So now I can't bury my lead. So what I am passionate about is people with dementia having a voice. And having, unfortunately, when you have dementia, you lose your voice. You lose your voice at the late stages, as Judy was saying, but honestly, you actually start to lose it much earlier than that. Once you're diagnosed with dementia, you're often ignored, patronized, stigmatized, and you start to lose your voice. But when people talk to me, as Connie was so gracious to introduce me, I'm a geriatrician and a palliative care doc. I've been taking care of people who have dementia, probably about 50% of my practice, most of my life. And they would say things like, I want choices, I want love, I want to not be a burden, I want palliative care, I want these things. But then whether it gets implemented or not is a whole different matter. So what Judy's brought up with the Dementia Directive is amazing because it helps them with their I wants. And what fascinates me about this next slide that I'm bringing up is these are experiences and expectations of people living with dementia. And it was just published last year. And I find that fascinating. We have known about dementia for a long, long time. 1900 is when Alois Alzheimer's coined the term, and people had been losing their minds from dementia even before that. But what we haven't done is ask people with dementia what's happening. And what they said was that the number one thing is they had that sense of a loss of control. And they hoped when they started to feel it that it was temporary. And then they got the diagnosis and realized that loss of control feeling was probably not temporary, but a symptom of their disease. They also lamented about their loss of role function, like their ability to work successfully or drive successfully, their loss of independence, and the increased stigma. They also talked about the uncertainty of the future. That was a big fear of many people. Then their fear of being a burden. And when they asked them in these interviews what gave them hope, how were they adapting, they said that they would adapt through finding meaning, and that meant looking for answers. So I think that's what Judy was describing. People were starting to come to her, knowing what the end of dementia is going to be like, and looking for some kind of solutions. They want to identify strategies to manage their problems, and then eventually they want to come to terms with their diagnosis. They want to stay connected, and they actually want to give back, and they usually do that through advocacy. So I think when they see this Dementia Directive, they may be our biggest advocates in getting it out there. In palliative care, we often think about palliative care physicians think of it as starting earlier. I personally think if I get a headache, I'm going to palliate it with some Motrin. But usually the focus is on therapy to modify the disease. Unfortunately with dementia, there is not much that can modify the disease. It is a disease that marches on. What it is it's a chronic disease. So we have years and years and years where we live with this disease. And so when we have diseases that are very long-term, we often don't think about the end. When we have hypertension or osteoarthritis, these are not necessarily terminal diseases, but they're long, and we think once you start an antihypertensive, you almost never stop it, unless somebody starts saying, is it still serving you? But with dementia, it's this chronic, progressive, long-term disease where we don't often make the shift to thinking about relieving suffering and improving the quality of life. And that's what I think the Dementia Directive is doing, is helping you say, where in this disease do I want to change the course of this disease? Where do I want to shift from living well with it to dying with it? And I think there is a place where you live with dementia and you can live very well with it, and then you start to die with dementia. So the things that Judy was bringing up were the things at the end, when we're starting to die with dementia, not when we're living with it. Hopefully what those people were saying with their experiences in the first slide was, I want to be an advocate, I want to have meaning, I want to have love. All those things are possible for a long time in this very, very long disease that can go on for 15 to 20 years. But you don't live with it the whole time, you start to die with it. In this slide, we look at the trajectories of death, and that's why I think we don't think of it very much. In sudden death, no big deal. You don't wake up one day. I mean, it's a big deal for the people left behind, but for you, it's probably a pretty good way to go. People with cancer, they actually do very well for a long time in their cancer. And then there's this rapid decline. This is where we often think of palliation, where we think of palliative care. You usually fight really hard to stay alive with your cancer, and then there's a point where you say, this isn't working out anymore, and you shift focus and you palliate and die. Again, you can, if you put that same framework on top of dementia, you would see that the Dementia Directive makes perfect sense, that there's a point where you live very well with your dementia, but then it's not going so well anymore. Heart failure, kidney failure, again, these are the things Judy was used to hearing about and having them come to End of Life New York, and where they have a little bit more of an up and down. But with dementia, you have the loss of function going on, and then this period of really being in the end of your disease is very prolonged. It can last on average between 3 months for people who have made choices or have comorbidities, so it's short, to about 3 years. So the average is well over a year. The average is closer to like a year and a half, living at the end stage. And then there's even people that Judy described today that tail is even longer. So I wanted to talk about a little bit of some of the progressions, some of the ups and downs of how we've been dealing with dementia over the years. In 1992, there was a paper published that said, should we tell someone if they have dementia? So these were physicians, these were geriatricians, these were like people who, we were treating dementia in 1992 like we were treating cancer in the 1950s. Let's not even tell them. That's not, nobody's gonna want to hear that. And so when you go to the doctor, and I don't think that's that dissimilar even now sometimes. We say things like, oh, you have a little memory loss, or you're slowing down a bit. Frequently I'm told by family members, we don't tell her she has dementia, and I'm like, really? I mean, I think she's got a clue that something's not right. People living with dementia, when they have surveyed them in different studies, show that their end-of-life choices are different than family members and different than healthcare providers, which again brings up how important it is to get their opinion about what they would want at the end of their life. Some of the good news is that physician referrals for hospice for advanced dementia are up from a mere 2.8% to 11%. So that's not actually that good a news. That means 89% of people with advanced dementia are not offered hospice. So that, in my opinion, that's a big number. It's better than 98%, but it's not great. And the other is that tube feeding insertion has declined by 50% since 2000 to 2014. That is very good news as well, that we aren't offering tube feedings for people. And study after study has shown, and most organizations agree, that tube feeding is not beneficial to those with advanced dementia. In fact, it's harmful and reduces quality of life. But we still have people getting tube feedings in 2018 for advanced dementia. Tube feeding has a place for certain people, but it isn't appropriate for somebody with advanced dementia. So when we talked about proxy caregivers, surrogate decision makers, this is people who have been surveyed who are proxy caregivers. And what they say is most of the time they want comfort for their family member. 63% say that they want complete comfort, comfort only, food for comfort only. 31% say they would like basic care, things like antibiotics and maybe a trip to the hospital, but not hydration, not tube feeding, anything like that. And 6% of people who care for somebody say that they would do something as extreme as intensive care units. So caregivers don't want very aggressive treatment usually. They see that advanced dementia is a terminal issue. But what this study also found, what I think is the most important part of this study, is that healthcare was not addressing end-of-life decisions with these people. Only 13% of these families had heard from a healthcare provider that maybe it was time to start backing off. And 8% were still being hospitalized at this very, very late stage. And here's one of the scariest parts to me, is that families are reluctant to face that dementia is actually a terminal disease. And if the child was the proxy, they were much less likely to choose comfort. And that's because it's so emotionally tied. To say, I don't want to do anything more for my mother or my father is very, very difficult. Oops, I'm going the wrong way. This is, again, I worked in a hospital before I semi-retired, and this was a common consult that I would receive. The patient wants to die, the family isn't ready. This is what I was frequently told, and so you need to go in there and start getting everybody on the same page. If this was somebody with advanced dementia, or I mean, we could query ourselves. When I sit down with people and say, if you were told you had dementia, how would you want the end to be? Most people say, I would want an exit strategy somewhere. If this is the continuum, you can change it, but it's usually never here. It's very, very rarely way over here. It's usually somewhere over here, and I think with advanced dementia, most people want to die, but the family might not be ready. So that brings me to when does healthcare at least think it's ready? And so there's the criteria for hospice, and I cannot believe how many people even realize that dementia has an eligibility for hospice. Many physicians don't even know that. But it's usually when you get to a stage 7C on something called a FAST scale, which is a functional assessment scale test, and then one or more of the following conditions are present. So I don't need to go through this, but it's just really to highlight that hospice is available and that there are criteria. And so what Judy wanted me to talk about was, what is that FAST scale? How do we decide when you are in advanced stages of dementia? It's a 7-point scale, and the first 5 are pretty easy. 1 means you're normal. 2, you start to lose some objects. I'm probably at about a 2 to 3 right now. I have decreased job functioning, and it's probably evident to my coworkers, maybe evident to some of you in the audience. Stage 4 would be decreased ability to perform complex tasks like planning dinner for guests or handling finances. This is when people are still living very well. They're still enjoying going to museums. They're still enjoying music and family. Everyone's still doing very well, and these stages, stages 3, 4, 5, last for 10 years. They can last a long, long time. And stage 5, you start to need some help choosing clothes. My mother had dementia, and she would, and I'm from the Midwest, and it can get very cold in the winter, and she would go out with like a little windbreaker, and then would forget to put gas in her car. So she would run out of gas with a little windbreaker on, which could be life-threatening, but you know, really it was stage 5. If we just kind of cued her up on a lot of things, she did very well on her own. It's at stage 6 and stage 7 that we start to get the more advanced stages, and this is where I think Judy's talking about people potentially implementing the directive. At stage 6, they start to bullet it out a little bit more so people understand what's going on. But when you start getting towards the end of stage 6, stage 6 is considered moderately severe dementia. When you can no longer successfully toilet, when you can't go into a bathroom and wipe successfully, remember to flush, when you start to become having urinary or fecal incontinence, you're getting it pretty advanced. And when I talk to people, they say, if I cannot take care of myself in a bathroom, that is frequently a point where a lot of people say, I would want to leave then. That's a dignity issue. That's where people start saying, I don't want to live like this anymore. Stage 7 is when you start to lose your speech, when you lose your ability to walk, when you start not to be able to sit up without assistance. If you were in a chair without arms, you might fall over. When you can no longer smile, and when you can't even hold your head up independently. So hospice kicks in when you are no longer able to walk independently. That means when you're starting to fall, when you need someone to walk with you. It doesn't mean you can't walk, and we all, many of you, if you are clinicians, know there are people who will be almost bedbound or confined to their bed, who occasionally will get up and walk to another room. That doesn't mean they're independent ambulators. That means that some dream, some hallucination, something got them so motivated that they remembered how to walk for a short period of time. But mostly, if they're falling, if they're not able to walk independently, they would be eligible for hospice. And with that in mind, again, what is your exit strategy? And so when I'm counseling people, I get asked several questions. Mostly I'm counseling proxies who are trying to decide when, but occasionally there are people who are asking me what's coming and what happens when I get it in an advanced stage. So these are the concerns I often hear. Why does she accept that food? And Judy already mentioned it. There's a reflex response occurs where you can get your mouth to open. Some people, if you don't actually go to the side of the mouth, if you just offer food towards the front and don't touch the lips, somebody who wants food will open their mouth. Somebody who doesn't, they won't. So you can avoid that reflex by not going towards the side of the mouth or actually touching on the lips. And you can still see if they want food. And when people know that, they're like, oh, okay, I can handle that difference. Will she be in pain if she doesn't eat? There's very limited data on that, but the levels of discomfort decrease after foregoing food and hydration. Dehydration and lack of nutrition actually brings out a natural anesthetic in us. And so most people are very comfortable not eating. Is there any risk to eating? That some people actually say, but there's no harm in eating, right? But there is. When you're forcing people to eat, your chances of choking and pneumonia go up. And when you do that, your quality of life goes down. It's much different to not eat and be quiet and in some sense of natural anesthetic versus being forced to eat, choking on something, losing your, you can't be comfortable right then. I hear this one all the time. She doesn't have to eat, but she has to drink, right? She has to drink. The studies have shown that that if you push fluids, you will prolong the dying process. You're not changing the trajectory really all that much, but you do prolong it, and you increase secretion. So you increase the gunkiness and the throat and in the lungs, you increase urination, you increase defecation, you increase sweating. So all those things are not the most comfortable when you're being cared for 100%. So you actually increase the amount of care they need and not the amount of one-to-one comfort they could be getting from someone. So it's much easier to take care of somebody who isn't that hydrated and then offer them love rather than offering them bed sheet changes and things like that. And then one of the more important questions is how long can she last if she stops eating and drinking? Most people die within a week. Over 60% die within a week. If you think about Nora, who was young, it may take longer. She's young, her heart's good, her lungs are good. Somebody with dementia who's young, honestly, lasts a bit longer. But somebody who's 99, like Margot, would die faster because of the comorbidities and the lack of reserve they have. But most people die within about a month, but usually within a week or two. And those are usually the questions I hear. I've got references that I will pass around, but again, if you have any questions, I'll be happy to answer them later. But that was my charge today, and I hope it's what you needed. Yours is down here, I think.
Hello.
Hello.
Everyone. I have an instruction. Take a deep breath. One more. This is a stressful subject. No surprise there, right? And we tend to stop breathing. Well, and oxygen to the brain is the best medicine. So I'll remind you later to take a deep breath again. Usually at these kind of talks, there's a form you have to fill out. If it's a CME program or a CLE program, you have to disclose your conflicts of interest in writing and then to the audience. Usually they're concerned about financial conflicts of interest, ownership in a product, or funding from a pharmaceutical company. I don't worry about that so much, but I have a conflict of interest to disclose. This is obviously my profession, bioethics. It's kind of all I do. But this is also my life. So you are entitled to know that my mom has moderate to advanced Alzheimer's. So my perspectives are informed by my scholarship and my professional activity and my teaching. A bunch of my students are scattered around the audience, so watch out. But also by my personal experience. So my mom was living in an independent living facility in Riverdale in the Bronx, and she got evicted. They threw her out. I actually have the eviction letter. They evicted her because she liked to go for walks along the Hudson River. You know, sometimes she went for walks with her imaginary friend. Not that there's anything wrong with that, but they decided they didn't want the responsibility, even in an independent living facility, for someone who was suffering from visual and auditory hallucinations and would go for walks. So we moved her to New Jersey for reasons that could be the topic of a whole other conference. And she's now in a memory unit, and for the last year or two she's been deteriorating because, as Anne said, dementia never gets better and it never stays the same. And if that weren't bad enough, we can't even predict when it ends. So, I mean, at least if you know it's not going to get better, it's not going to stay the same, it would be nice if we knew, okay, so how long is this going to take? We just don't know. We need to do some research on that. So that's where we stand today. My job today is to limit myself to discussing the legal environment in which all of these care decisions and ethical decisions have to be made. I'm happy to discuss lots of other dimensions of this. If you have questions afterwards, I'll stay as long as you want. But we need to understand eating and drinking and the law, what this is all about. We need to understand how we got here. There's some interesting legal history. And we need to understand where we can go. That is, what's the good news? How can we assert our independence and our autonomy in a way that the legal system will respect? Wrong way. So when did this all start? Kind of 1987, which happens to be the year I started practicing law, so it's sort of a good frame of reference for me. Julianne Delio, who I only in recent years got to know rather well, because we're both members of the same club. But when she was a young woman, her husband had an adverse event, as we like to say in healthcare, and wound up in a persistent vegetative state or mentally conscious state at the Westchester County Medical Center. And after a time, and when it became clear to Julie, who was herself a healthcare professional, that her husband was not going to get better, she wanted the feeding tubes removed. No one had ever brought that up before in New York, or at least not in a way that wound up in court. And so she went to court and asked the judge for permission to discontinue her husband's feeding tubes. She had to do that. Why? Because the hospital wouldn't let her make that decision on her own. They were afraid. Just a straight liability, risk aversion reaction. And the court agreed. This was the appellate division in the second department, which was Long Island and Westchester. And Westchester Medical Center sort of swallowed their pride and allowed the feeding tubes to be removed, and Julie's husband passed. Oops. Just a year later, it happened again at Westchester County Medical Center. Go figure. So this time it was someone named Mary O'Connor, and her family wanted to discontinue artificial nutrition and hydration. Mind you, artificials. We're talking about tube feedings. Nasogastric, PEG, through the abdomen. And Westchester said, well, you know, we got jammed up on this last time. We said no, we were humiliated. This time we'll go to court and ask for the judge to give us permission, based on what the court said in Delio, to discontinue the feeding tube. And they went to court, and you know, they just could not get a break. Different set of judges. This time it went all the way to the state's highest court. And the judge who wrote this decision, Judge Wachtler, who went on to infamy for being disbarred because he was stalking his girlfriend's daughter. Anyway, Judge Wachtler, fortunately or not, stuck around long enough to write the decision in the O'Connor case, which dismissed the finding in the Delio case and established what became the law in New York for over 20 years, and that is the clear and convincing evidence standard. It's the highest standard we have in civil matters, sort of equivalent to the beyond a reasonable doubt standard in criminal cases. And so in O'Connor, Judge Wachtler wrote that unless there is clear and convincing evidence of what the patient's wishes were when they had decisional capacity, you have to provide all possible treatment. And by that, he meant, although he wasn't brave enough to come out and say it, until the flesh rots off the bones, right? That's the standard. ICU, feeding tubes, ventilator, vasopressor drugs, the whole 9 yards. It was a nightmare. And that gave rise to New York's adoption of the healthcare proxy law. This was the product of the New York State Task Force on Life and the Law, the preeminent bioethics public policy organization in the country, that said we need a law that enables people to give instructions and authority to make these decisions, including the decision to discontinue artificial nutrition and hydration. As Judy pointed out, nobody was thinking about oral feeding. It just wasn't on our minds at the time. So the healthcare proxy law begot the guidance, a legal term, from the New York State Department of Health. This publication from January of 1991 is in fact still available. It's interesting reading from a historical perspective because the language used and sort of the emotion behind the pronouncement that yes, it's okay for people to make decisions when they have capacity that will be binding when they don't have capacity. It's not a radical notion in the law, and especially not in New York State, that patients ought to be able to make decisions, not just medical decisions, all decisions about what's done to their body, right? 1914, Judge Benjamin Cardozo, who has a law school named after him, I teach there, said in the case of Schloendorf versus the Society of New York Hospital, right down the road, I was born there, every person of adult years and sound mind has the right to control what is done to their body. It's the very first thing I say to my students every semester, because it is literally the starting point of the intervention of the law in the practice of medical ethics. So the guidance says, must evidence of the patient's wishes about artificial nutrition and hydration be written on the proxy form? Answer, no. All the form has to say is, my agent knows my wishes. Now, many people ask me, well, why did they put that in the law? And the answer is, there's no reason. It was a political decision. It was the way the tension between the people who wanted surrogate decision-making and the people who didn't want to allow surrogate decision-making reached a compromise that could get a majority vote in the New York State Assembly and in the Senate and get signed by the governor. So there you go. That's the law. Can an agent's decision conflict with what the proxy says in their advance directive? The general answer as a matter of law and as a matter of clinical bioethics is no. The agent has an obligation to make a decision on the basis of the instructions left by the patient if those instructions provide appropriate guidance. When they don't, typically because some lawyer drafted an advance directive that's either over-inclusive or under-inclusive, or lots of times simultaneously over-inclusive and under-inclusive, some lawyers ought to stay away from healthcare proxies. Most lawyers should stay away from healthcare proxies. Most patients should stay away from lawyers when it comes to healthcare proxies. More on that when we wrap up. So we're supposed to follow the explicit instructions of the patient. That's Schloendorf. When the patient is no longer able to speak for themselves, a patient is supposed to be respected by following the wishes that they left behind when they did have decisional capacity. That's prospective application of the patient's expressed wishes. If that doesn't work, we switch to substituted judgment, which is a standard that says you can infer from what the patient did say about a particular scenario, what they might say about one that they didn't anticipate, if you can establish a logical connection. And then, and only then, and this is the point made by the second frequently asked question, then we switch to the best interest analysis. And that's the surrogate making a decision based on what they think the patient benefits from where there is no guidance from the patient at all. So fast forward to where we are still today from 1991, right? We have the healthcare proxy law, and my understanding is that more like 10% of New Yorkers have prepared any sort of advance directive. We don't have great data on that, but it's a problem regardless. And it's a problem because of this. This is the Code of Federal Regulations, and I put this slide up here not so that you could read it because it comes off the computer in funny colors, but just so you know, this is where the rules live on what are called the conditions of participation. Those are the rules that CMS, the Centers for Medicaid and Medicare Services, apply to people who are in some sort of a custodial care, a hospital, a nursing home, a skilled nursing facility, assisted living facility, that's paid for by Medicaid and Medicare. And this is what most people in nursing homes hang up on when they are approached by a patient or a family member who says, I don't want to eat anymore, please stop bringing me food. And it's because of this abuse notion, right? So the conditions of participation, the federal regulations, and this is federal law, it's going to become an important distinction in a moment, defines abuse as the willful infliction of injury, unreasonable confinement, intimidation, or punishment with resulting physical harm or mental anguish. Abuse also includes, this is the important part, the deprivation by a person, including a caregiver, of goods or services that are necessary to attain or maintain physical, mental, and psychosocial well-being. Immediate jeopardy means that circumstance where immediate adverse effects will be visited on the patient, and neglect is kind of what we think neglect is, right? This is all just here so that you can look at them on your own time when you ask for copies of all these slides. So, how does this operationalize to make life difficult for actual patients in facilities funded by the government? And this is how. There's something called the State Operations Manual, and specifically the guidelines that the inspectors, they call them surveyors, they're not surveyors, they're not just gathering information, they're enforcers, let's be clear. This is the standard by which the surveyors are supposed to evaluate the care provided by a residential facility, let's just call them nursing homes, when there's some sort of a concern or a complaint or a whistleblower. So the standard E is failure to provide adequate nutrition and hydration to support and maintain health. And that little box is why nursing homes are so universally unwilling to allow patients to refuse treatment. But then you go to the details. The box on the right is part of a column of what to look for. This is the instruction given to the surveyors. Food supply inadequate to meet the nutritional needs of the individual. Well, that might be a problem. 2, failure to maintain adequate nutrition and hydration resulting in malnutrition, example, severe weight loss or abnormal laboratory values, electrolytes out of whack. 3, this is the important one, withholding nutrition and hydration without an advanced directive, and lack of potable water supply. I don't know what that's doing in there.
It's if you're in Detroit.
So, the State Operations Manual also gives instruction to the surveyors about how to look at typical situations so that the surveyors know how to enforce the rules in a somewhat consistent manner. So during the investigation, the surveyor, this is a case study, surveyor finds that the chart does not include a copy of the patient's advance directive. The progress note does not contain any documentation of the patient's ever stating a wish to have nutrition and hydration withheld. Meaning, the converse. If you have stated your wish, and if it's recorded in the medical record at the nursing home, and there's an advance directive to support that that was the patient's decision made when they had decisional capacity, you would not fit into this definition of neglect and immediate harm. So that's the federal rules. And the reason that those rules, let's go back a second. The reason that these rules just refer to the absence or presence of an advance directive is that advance directives are not controlled by federal law. We live in a republic, we work under a system of federalism where there are different levels of law. So the federal government says, for example, in the Patient Self-Determination Act, that every patient who's admitted to a hospital has to be asked if they have an advance directive, and if they don't, they have to be offered the opportunity to complete one. That's it. State law determines what is required of an advance directive, what discretion the advance directive can confer on the caregivers or the surrogate. Surrogate's a tricky word in this conversation because it means different things in different situations. It is what I like to describe as a homonym problem, when one word can mean two related but completely different things. Think of marriage. It has a religious connotation, and it has a secular governmental connotation. Same thing with surrogates. So a healthcare agent, which is what the person appointed to make decisions by a healthcare proxy, a document in New York State, the healthcare agent can make decisions in the role of a surrogate. But in New York, we save the word surrogate to describe someone who is not a healthcare agent and derives their authority from the Family Healthcare Decisions Act, which is a grant of authority from the state of New York, not a grant of authority from the patient. So that's why this state and federal law situation is important. So as recently as 2005, in this case, Bornstein, a judge in Queens, decided that because the patient, though she had appointed her daughter as her healthcare agent, because it wasn't abundantly clear, almost to that clear and convincing evidence standard, it wasn't clear that the patient had given the daughter specific instructions about artificial nutrition and hydration, a PEG tube, that the agent would not be allowed to make those decisions. Which is why every healthcare proxy, the form, ought to say, my agent knows my wishes about artificial nutrition and hydration, or not artificial nutrition and hydration. So, where do we go from here? What's there to be hopeful about? Well, first, everyone must appoint a healthcare agent. Every clinician has a legal, professional, ethical, and moral obligation to facilitate that. I'll be teaching a course in the fall at Columbia, Advanced Clinical Ethics, End-of-Life Care, to train people how to have this very difficult conversation, because we need to be having that conversation more. So, also appoint an alternative agent or two. So I, for example, appointed my wife as my healthcare agent, because you kind of have to, right? But I also appointed my son as the alternate, because I know my wife will not want to make these difficult decisions. You'll see why in a moment. This is my advance directive. Now, I have seen advance directives drafted by lawyers, usually real estate lawyers or people who do commercial transactions that literally go on for 10 pages listing every disease state known to mankind, humanity, and contingencies. You'll be able to get this, so if you want to take pictures, go ahead. Oh, that's you, Dan, one of my students. This is in your class handout. So you can prepare a very complicated advance directive with lots of contingencies and still wind up missing the one that the patient actually finds themselves in. This works for me. It's very simple. I do not want to be a potted plant. It's important to set the context. If I am unable to express myself and show signs of experiencing joy, gotta be both, I want all but pain care withheld so that my passing can come quickly. Now, by my reckoning, that covers both artificial and spoon feeding. Because,
Unless you write it down, pal.
well, I've done that too. Because remember Schlauendorf, Cardozo, 1914, every person of adult years and sound mind has the right to control what is done to their body. Organs to the living, body to science, then to the sea, and then a reminder, smile and breathe. Everyone, take a deep breath. So that's the legal context in which we are about to launch on the next phase of our public policy mission. Some of us in this room, Judy included, spent 17 years just getting the Family Healthcare Decisions Act passed. And that also has that limitation on artificial nutrition and hydration. This should not take as long because we do not need any new laws. What we need is activism, which is why all of you need to go home today and talk to all of your friends and download Judy's advanced directive and spread the word. And every single one of you should be talking about this topic at every single family holiday. Thank you.
Have the conversation. Yes.
So now, we're all going to have to use a microphone if you want to speak or ask questions, give any responses, concerns. So you can do this either through the panel as a whole or address specific panelists or just make comments. But please stand up to the microphone if you do that. Who would someone, yes.
Hi, my name is Joan Bates, and I enjoyed listening to all of you. 2 questions. Number 1, can a doctor or an MRI show the difference between normal age-related memory loss versus the beginning stages of Alzheimer's or dementia? And are there differences between normal age-related memory loss and the beginning stages of dementia? That's one question. And my second question, and please excuse my ignorance, is there a difference between a healthcare proxy and a, what we call a directive?
Advanced directive?
Yes. Are those 2 separate?
I'll clarify that after
Okay.
Ann answers your medical question.
So there is a difference between normal aging and the disease of cognitive loss that is considered dementia. Dementia can be several different things: Alzheimer's disease, vascular dementia, Lewy body dementia, several types. The most common type is Alzheimer's disease. An MRI cannot tell us if we have Alzheimer's disease, but there are PET scans that can give us good indications. They're not commonly used yet. There also can be some indication by cerebral spinal fluid testing, but usually with paper and pen tests with a neuropsychologist, we have a good idea if you're starting to get the changes consistent with dementia versus normal aging.
And
So
there is a difference though, right?
there is definitely a difference.
Between normal age-related memory loss versus
Yes.
the beginning stages
There-
of dementia/Alzheimer's.
There is definitely a difference. One is normal, and then dementia is not normal. There's definitely abnormalities. It is much more common the older we get, and at about 85, nearly 50% of people will show some signs of dementia, 85 to 90. So it's pretty common, but it's
Right.
not normal.
If you want to speak, you'll have to go. Okay. But I think that
So-
we should.
Yeah, let's let other people have a conversation.
Let me answer your second question very quickly. Advanced Directive is the broad umbrella term for all sorts of instructions, so living wills, healthcare proxies, durable powers of attorney. In New York State, the document is called a healthcare proxy. The person is called the healthcare agent. In other states, both the form and the person are referred to as a healthcare proxy. The words aren't terribly important. What's important is that you designate someone who has legal authority and they know what your wishes and values are.
Okay, so it's, thank you.
And I just want to say that when you do, the second part of what David said was very important. The statistics show that 2/3 of people fill out these forms and never speak to anyone about them. So if you don't want to be in that 2/3, you want to be in the 1/3 that tells people what you want.
Thank you.
I guess one of your former students. I actually just wanted to mention, but I do have a question, and that is, I read.
Put the mic down a little bit. Right.
I need to be taller. I'm not wearing my heels. There was an article that came out of the Mailman School where they were actually able to differentiate by some either receptor binding or some central nervous system transmitter. They were able to actually differentiate the normal aging process from other forms of dementia, which I thought was really interesting. But I just read it in a Columbia newsletter, and I didn't read the, but I thought that was a really interesting phenomenon that they had been able to.
We need to be doing a lot more of that kind of research.
Yeah, so I thought that was great. My question is either for Judy or Anne. I think it was Judy that mentioned that there was a decrease in the number of people requesting tube feeding or gastrostomy tubes. And I'm just wondering if that's because people are aware of the fact that it's, you know, not a very positive experience in terms of prolonging life, or is it because long-term care facilities often will not keep patients there if they have tube feedings or gastrostomy tubes, and they're there, they would have to go to another location?
It's a combination of all of the above, but mostly it's research. Research that's been done by geriatricians who have demonstrated that tube feedings inserted in people with advanced dementia doesn't prolong their life, doesn't lessen their calorie loss or their weight loss, it doesn't improve healing, it doesn't do any good at all, except charges Medicare a whole lot more money, because you can charge to hang this thing much more than, sadly, you can charge to have somebody stand there and feed you and talk to you. So I don't know, I think actually nursing homes used to prefer having patients with tube feedings because they were a lot easier to take care of. They didn't have to stand there and feed them. But clearly now, the evidence is unquestionable that they don't benefit the patient. And believe me, it's not the patient that's asking for tube feedings. You understand that, right?
That's
What
right.
often happens is the physician, and correct me if I'm wrong, Ann, the physician in the long-term care facility sidles up to the daughter often and says, you don't want your mom to die of starvation, do you? So maybe we better put tube feeding in.
That's exactly right. The other thing about tube feedings is not only are they not beneficial, the research has shown that they're actually harmful. The chance that you need to go to the emergency room quadruples when you have a tube feeding because they get pulled out, because they clog, and they cause pain, they cause so much decreased quality of life, so that the American Geriatric Society, the American Association of Hospice and Palliative Care, most societies recommend that they're not used, and that's why some of the numbers are going down. And it is frequently uninformed physicians. When I was an inpatient palliative care doctor, I actually had nurses come to me and beg me to talk to some of the hospitalists who say, it was frequently hospitalists who are usually relatively newly trained physicians who don't have enough experience yet to have the tougher conversations that David was talking about. Mm-hmm. And so I went up to several tearful physicians and said, what are you doing? And they said, well, I have to offer something. And I said, you know, compassion, kind word, that's something. You don't have to offer tube feeding.
No, it's not that
It's risk aversion, that's really what it is, and it's failing to recognize that what you can always offer is just presence, just being there for the patient.
Right. I guess that's one of the problems, though, is that the families are often, they're unrealistic. I think
That's why we're here today.
I just think they need some education.
Yes, that's right. Next.
Next, yeah.
I'm Claire Davenport. I'm over at Mount Sinai in the Hospital at Home program. I'm attending.
I can't hear you.
Microphone up a little bit.
I'm Claire Davenport. I work at Mount Sinai.